For the opportunity to share some thoughts with you about how we can consider respiratory health and the life course evolution of chronic lung disease in the context of imaging, as well as sort of more broadly as we think about how to conceptualize impaired respiratory health. These are my disclosures, some consulting and research support with some industry partners. I want to take a moment just to talk about how the respiratory community has typically defined health and implicitly then defined disease. Lung health in adults has traditionally been defined as the absence of disease. Early disease then becomes defined as the first appearance of abnormal lung physiology. And that works perhaps finding early disease if we want to test today's therapies. In contrast, I make an argument that thinking about lung health and how to preserve and idealize and promote lung health is critical for disease interception. The trajectory of decline following attainment of peak lung function is variable. But in the respiratory community, we actually only seem to care if it declines into a threshold into the disease range. For example, an FEV1 below 80% of predicted, or an abnormal FEV1 to FVC ratio. And then outside of smoking, there actually are limited data on factors associated with maintenance versus decline in pulmonary function. I'd be remiss if I didn't talk about sort of the historical perspectives on lung function decline, the Fletcher and Peto curves, which ascertain that in susceptible smokers, there's an unrelenting decline in lung function. And if someone quits smoking, there's no way to restore someone to their ideal respiratory health. Of course, this notion that people wake up every day with a little bit less lung function than they had the day before is a conceptual model and probably not true. And perhaps we ought to think differently about how to maintain a straight line across lung function as the life course progresses. This was modified by Burroughs et al., who sort of acknowledged that there's a lower limit of normal and people may not have the same peak lung function in young adulthood, and that there may be episodic declines with restoration to occur in people who experience lung function decline. This, of course, became all the more newsworthy over the past 5 or 6 years, largely informed by this important paper that Peter Lang and Bart Celli and Albert Augusti were the co-lead authors on, that combined information from multiple cohorts to really depict that now in the 21st century, there are 2 pathways to COPD. There are people who on the left side have normal lung function at baseline and then have accelerated decline in lung function. But there also are people who start out with abnormal lung function at baseline and have less decline in lung function, but both of these groups had COPD defined by spirometric FEV1 to FVC ratios less than 0.7. Our group actually reported similar data using the Cardia study, whereby we looked at people who had abnormal FEV1 to FVC ratios between the ages of 38 to 50 and what their FEV1 trajectory was across their age ranges. And we really found that people who had obstructive lung physiology between the ages of 38 and 50 had sustained lower lung function from the time they were really early in adulthood, in contrast to those who had no evidence of obstructive lung physiology. What about these trajectories and how they lead to disease? Well, this is work that my friend and colleague George Washko led in the Cardia study, whereby we defined trajectories of lung function in Cardia, which is a fantastic cohort of people recruited between the ages of 18 to 30 in 1985, and now followed 30 to 35 years later. George looked at trajectories of FEV1 decline in Cardia, and we actually came up with this depiction of lung function, whereby there are people with persistently poor lung function, there are people with ideal respiratory health, and there are people who have declining lung function or preserved impaired lung health. We looked at the prevalence of an abnormal FEV1 to FVC ratio in these folks, and we found that people were had abnormal lung function across the spectrum of this in terms of FEV1 over FVC, but the prevalence of abnormal lung function was greatest among those with persistently poor lung health, next highest prevalence among those with worsening lung health, and then people who had this intermediate phenotype of preserved impaired respiratory health And FEV1 that sort of stayed around 90% predicted across their life course actually had a significant proportion of people with obstructive lung physiology. We then looked at people and whether they had abnormal CT scans. In this case, we looked at the visual emphysema and the prevalence of it. We found that people who had both persistently poor lung health, as well as those who had worsening lung health and accelerated decline in lung function, had similar prevalence of emphysema. And again, this intermediate phenotype of preserved impaired lung health had more emphysema than groups who had preserved good lung health or those with ideal respiratory health. There are other ways maybe to phenotype respiratory health. In an analysis of cardia, we actually asked the simple question of what if people have respiratory symptoms between the ages of 25 to 27, and would that portend risk of future chronic lung disease? And it turned out that people who had symptoms between the ages of 25 and 27, if those symptoms included cough or phlegm, wheeze, or chest illnesses, had greater odds of future obstructive impairment. And in the case of cough and phlegm, as well as recurrent episodes of bronchitis, it predicted future emphysema on CT scans. In contrast, reporting shortness of breath between the ages of 25 and 27 was associated with the development later in life, 25 to 30 years later, of restrictive physiologic impairments. We don't really know, though, what's going on in the lungs of these people who report symptoms. And perhaps that's, in my view, where the opportunity for utilizing novel imaging techniques could really emerge. One imaging technique that we've become really keen on is the local histogram technique, which has been developed by George Washko and Raul San Jose in their state-of-the-art imaging group. And we've endeavored to put forth the notion that you could use this to create a lung health map. So their characterization technique can characterize areas of lung across a variety of features. And I just want to call attention to one feature, the normal high attenuation feature, which we actually now have termed lung injury. Information from Raul and George's group has put forth this notion that we can use this feature to look at a variety of things. This feature is associated with some increase in biomarkers, ICAM1 and C-reactive protein in both COPD gene as well as in cardia, are both increased in people who have greater burden of lung injury on their CT scan. And it's important to note that we have reported that both CRP and ICAM1 are associated with future lung disease, both future interstitial lung disease, as well as emphysema. In addition, lung injury is associated with future structural lung disease, both central lobular emphysema over 10 years in cardia. The burden of lung injury is associated with a significantly increased odds of the development of emphysema, as well as interstitial abnormalities several years later. What about the intersection of biomarkers and CT lung injury? Well, this is really interesting, that only those people who had a higher burden of CT lung injury did the biomarkers I just told you about predict future structural lung abnormalities. So in those people with CRP and high ICAM1, those who had a high burden of CT lung injury had a much greater odds of developing interstitial features 10 years later. So it's been said that we'll never find biomarkers in the blood of future lung disease because it's too much, it's nonspecific and this and that. But what if we ask the question about whether we could integrate blood biomarkers with a CT-based risk factor that depicted early lung injury and really define an at-risk group for future lung disease, and then view that as an opportunity area to actually test therapies that can intercept impaired respiratory health and prevent progression to chronic lung disease. I'll just wrap up and share our paradigm of lifetime respiratory health. And it really hovers around this intermediate phenotype, that there are people who have susceptibility to future lung disease. It could be due to actual susceptibility to lung injury. It could be due to impaired reserve. But to focus on disease interception, we need to think about these two yellow lines, the intermediate phenotypes, and how we can actually intercept them before they descend towards a disease threshold. So some concluding thoughts to maybe inform the discussion going forward. Ideal lung health is more than the absence of lung disease, and impaired respiratory health is associated with a number of adverse health consequences. I didn't even mention all of them, but that intermediate phenotype of impaired respiratory health, where people have decrements in lung function that are not below a threshold of abnormal and may have CT abnormalities in addition, are associated with a number of adverse health consequences. Not only respiratory symptoms, but also impaired cognition later in life, high risk of cardiovascular events, and on and on and on. And disease-focused studies of people who already have lung disease, even when they include people with early disease, don't inform lung health or prevention strategies, nor do they enable interception strategies. Preservation of respiratory health is not solely predicated on avoidance of cigarette smoking. We think intermediate phenotypes of impaired respiratory health can be driven by a number of things, including environmental exposures and other things like respiratory infections, which are extremely timely right now, or other injurious stimuli. And I would argue that major gains in cardiovascular disease prevention are attributable to health promotion, and that the absence of disease-agnostic respiratory health studies in the US have hindered our efforts at prevention. We don't have the cholesterol of the lung, and actually integrating imaging biomarkers with traditional blood biomarkers present a clear opportunity. In a shameless pitch, I'll just point out that we are now recruiting a cohort of 25 to 35-year-olds across the country through the ALA, deemed the ALA Lung Health Cohort, where we actually are trying to collect the requisite information to ask some of these questions. These participants, age 25 to 35, will all get CT scans. We will get detailed environmental and behavioral exposure information on them, as well as health histories, and really try to define their respiratory health and follow them forward so we can think about whether this paradigm of biomarker discovery in conjunction with lung injury is an opportunity for us to answer these questions. That's all I have. Thanks for the opportunity.